Hello, welcome to the self-paced training on implementing measurement-based care, specifically on the use of the Patient Health Questionnaire 9 items, or the PHQ-9, to measure depressive symptoms. This training was offered to you as part of a research project funded by the National Institutes of Mental Health. The fund from this grant allows us to provide this training and CEU credits for you, cover your productivity requirement for completing this training, and pay for research personnel involved in this project. This research project is led by Dr. Cara Lewis from Indiana University and in collaboration with Centerstone Research Institutes and Centerstone clinics across Indiana and Tennessee. Since this is a self-paced training, feel free to pause at any time, take notes, and write down questions that you have. This is the agenda for the self-paced training and the approximate minutes that will take you to complete each session. In the first section of this training, I will provide a brief introduction, give you some information regarding the CEU credits, and go over our training strategies. Before we start the training, I'd like to spend a few minutes introducing myself. My name is Ajung Puspitasari. I am a postdoctoral fellow working with Dr. Cara Lewis at Indiana University. I completed my doctoral degree in clinical psychology, and my clinical work has primarily focused on clients who suffer from comorbid depression and chronic medical conditions in inpatient hospitals and primary care settings. I really enjoyed working with diverse client population, including perinatal women, refugee population, and underrepresented groups. In terms of the specific treatments, I am primarily trained in cognitive behavioral therapy, including behavioral activation and acceptance and commitment therapy. My clinical experiences have significantly influenced my research interests and the type of research questions that I'm interested to examine. Specifically, I'm interested to examine effective strategies to train mental health providers like yourself in evidence-based treatments and practices. So that's a little bit about me. I really wish we could now take turn and have you introduce yourself, because I would be very interested to also hear a little bit more about you and your background. Hopefully, though, we will have the opportunity to meet in person either during the follow-up consultation meetings that I will discuss later or when we come and visit your clinic. Just as a reminder, we will provide continuing education training credits for you for completing this online training. In order to receive your credits, we need you to complete the CEU survey that we have sent to you previously. Now I'm going to talk a little bit about our training strategies. So you could probably relate to this picture where training is filled mostly by didactic lecture and learning is a one-way street instead of a collaborative interaction between the trainer and the trainees. While the self-paced format is great because you could complete it at your own time and from pretty much anywhere, the training will rely heavily on me explaining the concepts to you. So as I previously mentioned, if you start to drift off and have difficulties concentrating, feel free to stop the presentation, get up, and resume when you feel more energized. Another point that I want to highlight is that this type of didactic training, where I do most of the talking and you listen, has the potential to increase your knowledge on the learned techniques, in this case measurement-based care. However, to actually increase your skill, more learning strategies need to be implemented. So what are some of the recommended learning strategies? I will discuss them in the next few slides. In the spirit of learning, one recommendation that has been shown to improve provider skills is to engage in active learning strategies. And by that I mean to actually practice implementing the PHQ-9, either before your session with a client, by filling it out yourself for instance, or practice using it with your colleagues before you see your actual clients, or actually using it with your client in therapy session. Learning a new therapeutic technique is similar to learning how to cook. It's not enough to just read the ingredients, understand the steps and the recipes, and discuss the plan to cook with your friends or family. You need to actually go to the kitchen and start cooking. I have tips and tricks on how to make this self-paced training more experiential on the next slide. Thus, we really recommend that in addition to listening to the self-paced training, you engage in other active learning strategies that have been recommended to improve provider skills. Throughout this presentation, I would recommend you to write down some questions, think about how the techniques that I cover will look like with your actual clients, and respond to the prompted questions that I have by writing the answers down. I have also sent you some handouts that you can use throughout this training. So another recommendation is to pull out each handout when prompted so then you can follow along this training by looking at the handouts and reading the information that we've included for you. Lastly, I can't highlight enough that the really important part of learning a new skill is to just practice, practice, and practice. And here are some more examples of active learning strategies that have been shown in the literatures to help providers learn a new therapeutic skills. Some of these strategies will be somewhat integrated into the self-paced training, and others will need to be done outside of this self-paced training. So the first strategy is modeling, or observing a trainer, supervisor, or another individual with more expertise using the therapeutic technique. We have included 2 videos in this training so you could observe how a therapist uses the PHQ-9 with her hypothetical client. If this is the first time you're using the PHQ-9, I would also recommend you to either observe a colleagues or your supervisor delivering a PHQ-9 with a client. The second recommended strategy is practicing, which I have mentioned multiple times before. And with practicing, we recommend you to actually use the techniques before implementing it with an actual client. This can be done through a role play with colleagues or using the new technique on yourself. In this training, for instance, we recommend you to test completing the PHQ-9 yourself if you've never done so in the past. The third active learning component is receiving feedback, which is very important to understand your own competency in implementing the PHQ-9. If you participate in this research study, hopefully you'll be interested to participate in the ongoing consultation meetings that we offer after this training. We will weave in the feedback during the follow-up consultation, and feedback will be provided by me or another research personnel who will facilitate the consultation meetings, or you can also receive feedback from the other clinicians who participate in the consultation meetings. Discussion is the last element of an active learning strategy, and it is very important since you may have some questions or concerns regarding implementing the PHQ-9 with your actual clients. So having a lot of discussions either with your colleagues or your supervisors is really important to help you implement this measurement-based care. In the next section, I will provide some information regarding our research project and what it means if you decide to continue your participation in this study. So the primary aim of this grant is to support the use of measurement-based care in community mental health settings such as Centerstone, and MBC has been identified as an evidence-based framework recommended to be used in clinical settings. The primary research question that we are interested to answer in this project is whether the standard implementation strategies guided by best practices is optimal for introducing MBC into community mental health settings, or if we need to add customized implementation strategies for each clinic when introducing MBC. The current standard best practices to implement a new evidence-based practice is to include initial training, like the one you're completing right now, followed by ongoing consultation, and by providing a guidelines on how and when to use the evidence-based practice. In addition to that, we are also interested to determine whether the recommended best practices of delivering MBC in every session is necessary to achieve client benefits, or if a modified schedule, for instance providing the PHQ-9 every other week or once a month, is comparable to doing it every session. So what does it mean if you're willing to continue your participation in this research? Some of this information you've probably heard from our initial meeting that we did approximately a month ago. In general, there are three main research activities that we ask you to do if you're willing to continue your participation in this study. The first main research activity is to complete survey packets at 3 time points. If you're already receiving the self-paced training, you've probably completed the baseline survey that we did approximately a month ago. We will also ask you to complete another survey packets 5 months after this training, or at the end of our active implementation period. After that, we'll ask you to complete the same survey again at 15 months follow-up, or at the end of the sustainment period. And you will receive $50 cash incentive each time you complete the survey packets. The second main activity is to complete this initial training, which is the self-paced training that you are listening to right now. And in addition to that, we will ask you to complete the small survey packets regarding our training and another survey to get the CEU training. And for your participation in the self-paced training, you will receive CEU credits, productivity requirement coverage, and $15 cash incentive for completing the survey. The last main research activity that we ask you to do is for progress notes data collection. And I will go back to this point and cover it in detail at the end of this training, the 3 questions that we are interested for you to answer. Initially, these 3 questions to understand your implementation of the PHQ-9 with your client was to be included in your progress notes in the EHR. Unfortunately, this process was not completed in time, so we had to use an alternative to collect this data, and we've prepared a questionnaire that will ask you to complete at the end of each week and I will go over that specific fidelity questionnaire in this training later on. In addition to the 3 main research activities that we ask you to participate in, we also have other optional activities that you can do if you're willing to. The first one is to participate in a focus group at one or all of the 3 time points. You've probably completed one focus group at baseline a month ago. And we may also invite you to participate in the focus group again at 5 months and 15 months follow-up. And you will receive $25 for each focus group that you complete. The third optional activity that we invite you to participate in is the ongoing consultation meetings after you complete the self-paced training. The consultation meeting will meet tri-weekly or every 3 weeks for 60 minutes each to support your MBC implementation with fidelity. You will meet with me or another research personnel who will facilitate the consultation meetings, and we also invite other clinicians and potentially office professionals to join these consultation meetings. You will receive 1 CEU credits for each consultation meetings, and we will have approximately 7 meetings in total in the next 5 months after this training. The third optional activity that we invite you to do is to provide audio recorded therapy session with your clients, approximately 1 to 3 of your clients for their sessions 2 and sessions 5. And the main goal to collect this audio recorded therapy is to help us answer and understand what does MBC implementation look like in actual therapy session. And we can provide you with more information regarding this optional activity when we start the consultation session after this training. And feel free to write down questions if you have more questions regarding this optional activity too. Lastly, the fourth optional activity is the exit interview. We are planning to invite clinicians to participate in these exit interviews over the phone, and each interview will last approximately 60 minutes or an hour. And specifically, we are interested to understand what was your experience in this research study like, and how did you use measurement-based care with your actual clients, and if there are other strategies or if there are other things that could be done to enhance the implementation process or use of measurement-based care in your clinical practice. If you're willing to complete this exit interview, you will receive $25 incentive for each exit interview that you complete. In the next section, I will spend some time to discuss measurement-based care as a foundational framework. And again, just to remind you, if you have any questions or concerns regarding your participation in this study, or if you feel like you need to get more information regarding our study, feel free to write the questions down and shoot us an email. I will provide our contact information at the end of this training also. The definition of measurement-based care is pretty self-explanatory. In general, MBC can be defined as systematic monitoring of client outcomes, progress, and symptoms to inform care decisions. Clinicians who's using MBC may use a standardized measure. In this case, we are focusing on the PHQ-9 as a standardized measure to assess clients' depressive symptoms. When we use MBC, we assess client symptoms regularly from the start of treatment, throughout treatment, and at the end of treatment. This way, we have a concrete data or evidence on our client's symptoms trajectory. So what does it look like when you implement measurement-based care in your clinical practice? We believe there are 3 main core components of implementing measurement-based care with your client. And I'm going to go over to these 3 main points over and over again throughout this training. And hopefully you can just spend some time to look at these 3 core components and memorize these three steps when we talk about implementing measurement-based care. The first core component is administering the self-report measure to your client. This means asking your client to actually sit down and complete the self-report questionnaire, or the PHQ-9 in this case. The second core component is for you to score and review the completed self-report measure with your client. And lastly, the third main component of measurement-based care is to discuss the self-report measure with your client during your therapy session. So now I just want to stop for a few minutes and prompt you with this question. If you have used measurement-based care in the past in your own clinical practice, I was just wondering if you could spend a few minutes to either think about or write down what did it look like for you to implement measurement-based care. One thing that you could think about is the type of measure that you use when you're implementing measurement-based care. You might also want to think about or write down how did it impact your practice? How did your client respond when you implement measurement-based care? And overall, what do you think is the benefits or barriers to complete measurement-based care? Some of the reasons that attract us to focus on measurement-based care is the fact that MBC is a core component of almost all evidence-based treatments, such as cognitive behavioral therapy and dialectical behavioral therapy. In these treatments, clinicians are really encouraged to regularly monitor their clients' symptoms not only in the beginning of therapy but throughout treatment. In CBT, for instance, we are encouraged to assess our clients' depressive and anxiety symptoms throughout treatment to inform our care and to inform the type of therapeutic strategies that we use to help our clients. Another reason why we are interested to focus on MBC is the fact that there are a lot of research evidence showing that self-monitoring alone improves outcomes. So we know, for instance, when we help clients to reduce their weights, regularly monitoring their weights can be a great strategy to help weight loss. There are two primary goals of using measurement-based care in our clinical practice. The first one is to help or teach our clients to be more curious about their emotional experiences, and to also participate more collaboratively in therapy sessions to learn what is affecting their symptoms and functioning. I often give this metaphor of consistently measuring their blood pressure when they go to their medical doctor. The idea is if we are informed regarding our blood pressure, first of all, we can get some alarm or signals when our blood pressure increases or decreases, for instance, and this signal can be used to alert us when to change our behaviors, when to exercise more, or when to improve our diets. So the same thing with measuring depressive symptoms regularly. If clients can understand their depressive symptoms more closely or more concretely, this can help them understand external circumstances, for instance, that may influence their depressive symptoms, or to use this as a signal or an alert for them to potentially change their behaviors, for instance, by improving their sleep or engaging in more social activities. The second goal of measurement-based care is to provide therapists with a more objective norm reference data to inform their care decisions. Because we are using standardized self-report measures, we already have some data on the general norm in the population regarding depressive symptoms, for instance. So if we ask our clients to complete the PHQ-9 regularly, we have a more concrete evidence to compare how our client is doing compared to the general population. Another thing is we have this concrete data on our client's baseline. So if our client is suffering from chronic depression, for instance, we know at the start of treatment that a certain score is probably our client's typical depressive score. And then we can also get a signal when the scores change, whether if they're improving or if they're doing worse, because we already have a baseline data from our client's depressive level or typical depressive level. In addition to the two main goals of measurement-based care, MBC also has other multiple purposes, and I will go over these functions in more detail later on in this presentation. But in general, MBC can be used to assist us when we're trying to make a diagnosis for our client. It can also be used to make differential diagnosis, for instance. We can use MBC as a screening tool, even for those patients who are not struggling with depression currently, if we regularly give them the PHQ-9. If, for instance, they're struggling with current life stressors and their depressive symptoms elevated, we can catch that increases earlier. MBC can also be used for prognosis or making other predictions in treatment, and I'll go over this point in more detail later on. We can use MBC to create our case conceptualization or case formulation. We can also use MBC to design our treatment or to make treatment planning. As previously mentioned, we can use MBC to monitor our client's progress regularly, and eventually MBC can also provide us with concrete data when we're trying to evaluate the success of our treatment. Now I want to take a few minutes again and just prompt you to think about if there are other potential functions or benefits of measurement-based care for you in clinical practice. If you've used MBC in the past, I was wondering if you could just write down some of the potential functions and benefits of using MBC for you and your clients. And if you've never used MBC in the past, I was just wondering if you could just think about and make some predictions on what types of benefits that you may gain if you start to use measurement-based care. I will spend the next section to share with you some research evidence that supports the use of measurement-based care in clinical practice. There are some potential use of measurement-based care that hopefully will benefit you and your clients in clinical practice. The first one is MBC can help us to efficiently detect treatment non-responders. Because we implement measurement-based care regularly at the start of treatment and throughout treatment, we can understand how our client is doing early in therapy. And we could monitor their symptoms change in the first 5 sessions, for instance. And if our client is not doing well, or if their symptoms stay elevated, for instance, we can catch this pretty early, and this can inform our treatment plan, or this can inform us to potentially consider maybe other strategies that can help our clients better. The second use of MBC is to prevent deterioration. So imagine if you are implementing the PHQ-9 to consistently monitor your client's depressive symptoms, for instance. You could see their symptoms trajectory from the beginning of treatment. And if for some reason, maybe due to some external stressors, your client is not doing well and their depressive symptoms elevated because you consistently use the PHQ-9, you could have a concrete evidence. And this sudden elevation on their depressive symptoms, for instance, can immediately alert you, and you can catch this deterioration immediately because you consistently monitor their depressive symptoms. On the flip side, this can also be an encouraging concrete evidence for your clients when they're doing well in treatments. For instance, if they're working really hard in treatments and they make significant changes in their life, and their depressive symptoms decrease, for instance, you could have a concrete evidence to show your clients that, hey, you're actually doing really well compared to the start of treatment. We also have some evidence, particularly in youth population, that when clinicians provide measurement-based care, it can also expedite treatment response. I want to go back to the previous point that I made on the fact that measurement-based care can help us to make prognosis or other predictions in treatment. I want to orient you to this research study conducted by Dr. Lewis and colleagues in 2012. In this study, what they did was they looked at different predictors of treatment outcome for clients who were seen in a community clinic. And what they found was that early depressive symptom change is a robust predictor of acute outcomes and follow-up above other predictors such as gender and age, as well as suicidality. So what it means is when clients are doing really well early in treatment, such as in the first 5 sessions in treatment, this can be a really great predictor of how well they're going to do at the end of treatment. And related to this, the importance of using measurement-based care is when we consistently assess our clients' depressive symptoms, for instance, we could see their progress in the beginning of treatment. So we can then really understand if they're doing well in the beginning of treatment, then we can be hopeful and share this news with our clients. The fact that they're doing well in the beginning of treatment can be a really good indicator on how well they're going to do long term. On the flip side, if we implement measurement-based care and then we notice that our client is not doing as well early in treatment, this can also be an alert for us to go back to the drawing board, for instance, and consider our treatment plan and consider potentially other strategies that may need to be implemented to help our clients do better in treatment. This is some other studies that I thought are really interesting and provide more evidence on the clinical utility of measurement-based care. So I want to spend a few minutes orienting you to this graph. In this study, clients were asked to regularly complete the outcome monitoring. So you could see on this graph the outcome questionnaire total score from 50 to 100, and higher scores indicate worse symptoms. And they assign clinicians and clients to different groups. So there are 4 different groups in this study, and they did assessment at 3 time points: at pre-test, in the middle of treatment, or what we call the feedback on this graph, and then at the end of treatment or post-test. So if you look at these 4 lines, there are they represent the 4 different groups or conditions that clients and clinicians were assigned to. So I want you to take a look at the first line with the red color and the square dots. For this group, what happened was clinicians and clients were assigned to the condition where clinicians did not receive any feedback regarding their client's symptoms. And in this group, clients were not doing as well. Their symptoms increases from pre-test to the feedback or in the middle of treatment. And then you could see their scores at post-test. And I want you to compare it to the second group where clinicians receive feedback. So in this condition, clients also did not do so well. After treatment started, their OQ scores increased, similar to the first condition. But the difference was for this condition, clinicians received some feedback regarding their clients regularly. And you could see that clients' symptoms decrease at the end of the study. The third condition was the line, the purple line with triangles dots. So for this group, you could see that clients were also not doing as well since treatment started. But what happened was in this group, clinicians in the middle of treatment received feedback on their client's symptoms as well as some additional clinical support to help them decide what kind of strategies that they should add to treatment. And then you could see that the client's symptoms decreased more than the first two groups at pre-test. Now I want you to look at the last group, or this blue greenish line with the square dots. So again, similar story. The clients in this last group did not do so well after the start of treatment. Their scores increased in the middle of treatment. And what happened was, at this point in the middle of treatment, the clinicians received feedback on their client's symptoms regularly, but the clients also received feedback on their symptoms. And this group, as you could see, this group was doing really well in terms of the reductions of clients' symptoms compared to the first three groups. So these studies can be another evidence on the benefits of regularly monitoring client symptoms, but also not only for the clinicians to understand the trajectory of the client's symptoms, but also the benefits when we share with our clients on how they're doing in terms of their symptoms. So in other words, the benefits of discussing our client symptoms after they complete the self-report measures. Another study that showed the clinical utility of measurement-based care that I want to highlight is this very recent published study in 2015. In this study, they look primarily at psychiatrists who implement measurement-based care for depression. And they randomly assign clients to either receive measurement-based care or usual care. And what's really interesting is the results indicated that patients who receive measurement-based care significantly achieve response and remission compared to those in the usual care. Specifically, 74% of those in measurement-based care group achieve remission compared to the 29% in the usual care. Time responses to treatment was also significantly different for these two groups, and they found that those in measurement-based care had time response of 5.6 weeks compared to 11.6 weeks for those in usual care. Remission for those in measurement-based care group was achieved within 10.2 weeks versus 19.2 weeks in the usual care. And they concluded that this might also be due to higher antidepressant dosages, and then more treatment adjustment for those in the measurement-based care group. Now I'm going to switch the focus from measurement-based care and talk a little bit more about the PHQ-9. And also I just want to share just a brief history of why we decided to focus on the implementation of PHQ-9. So in the past, I believe 3 or 4 years, our research team led by Dr. Cara Lewis has been working very closely with Centerstone Research Institutes and Centerstone clinics across Tennessee and Indiana. And we have had a lot of discussions on what type of self-report measures that will be most appropriate and beneficial if we're trying to study the implementation of measurement-based care at Centerstone. And it was decided that the PHQ-9 would probably be the most appropriate and beneficial tool implemented in Centerstone. So we decided to go ahead and study or focus specifically on the implementation of PHQ-9 in this project. And interestingly, you've probably heard that more recently Medicaid also took a lot of interest on improving the implementation of PHQ-9 in clinical practice. And if you haven't heard that Medicaid, because of this new interest by Medicaid, Centerstone has strongly recommended clinicians, particularly I believe in Tennessee clinics, to use the PHQ-9 particularly in the initial intake session with your clients and several other points in treatment. So I just want to share with you that interesting facts that both our research teams and then now Medicaid also take interest in improving the implementation of PHQ-9 in clinical practice at Centerstone. So my feeling is that you've probably implemented PHQ-9 at some point in your clinical practice with your client. So the good news is you probably are very familiar with this measure. And if this is your first time implementing the PHQ-9, we have included some PHQ-9 measures in the training packets that we left for you. So I was wondering if you could stop and just look at your training packets and pull out the PHQ-9 questionnaire that we've provided for you. And you could see that we've printed out the PHQ-9 form with the shaded section. So if you look at the PHQ-9 form, it has 9 items that assess clients' depressive symptom severity. What's really nice about these 9 items is that they map directly onto the DSM criteria for depressive symptoms. The other attractive feature of the PHQ-9 is item number 9, or the suicidality item. This way PHQ-9 can be used also as a tool to regularly assess your client's suicidality. Lastly, the PHQ-9 that you have also has the last item, or item number 10. And this item specifically assesses your client's functioning, or how the first 9 items impact different areas of their lives, or whether or not it impacts different areas of their lives, such as work, social interactions, and other important areas in your client's life. So in the next few minutes, I was wondering if we could spend a few minutes just being familiar with the PHQ-9. One thing that I would like to ask you to do is to actually spend a few minutes completing the PHQ-9 yourself. It's really interesting when we do this training in person and we ask clinicians to raise their hands if they themselves have completed the PHQ-9. And it's always surprising how many people said that they actually never completed the PHQ-9. So I was wondering if you could complete it yourself. And the reason is just to really understand the process that our client goes through when we ask them to complete the PHQ-9 for us. One thing that I want to note is before you complete the PHQ-9 yourself, I want you to notice the time that it takes you to complete the self-report measure. So I hope at this point you've completed the PHQ-9 yourself, and what I was wondering is if you could spend a few minutes just to think about that experience of completing the form yourself, and hopefully you also notice the time it took you to complete the form. My guess is you probably took about 3 to 5 minutes to complete the PHQ-9. This was based on our experience when we asked clinicians to complete the PHQ-9 themselves in our in-person training. So one thing that I want to highlight is how interesting that it just takes about less than 5 minutes to do this measure. The reason I point that out is because often as clinicians we overestimate the time that it would take our clients to complete this type of measure. Hopefully though, now that we learn that it doesn't take as much time to complete this measure, it can increase our hope to integrate the PHQ-9 into our therapy session. And later on, I'll talk a little bit more on different strategies that we could use so then we still save therapy session time even when we add this new component of measurement-based care. So now if you look at the slide in front of you, we've listed all the 9 PHQ-9 items in front of you, as well as the area where you could provide or you could count your client's PHQ-9 score. And towards the bottom is the box for item 10, where we ask how the previous 9 items affect your client's functioning. And again, it's really important to not only ask your clients to complete the first 9 items, but also item number 10, because in order to make the diagnosis, we need to make sure that this previous 9 items actually decrease your client's everyday functioning. Now I just want to also mention that in your training packets we have printed out some handouts on PHQ-9 implementation and basic information that's important for clinicians to know when they're using the PHQ-9 with their clients. So if you can just take a look at your training packets again and make sure that you have those information. So on this slide, I'm sorry that this slide is actually pretty busy and we have a lot of words on this slide. But in general, I just want to point out that after you score your client's PHQ-9, just a few things to remember: that if there are at least 4 check marks in the shaded section of your PHQ-9, which also include either question number 1 or question number 2 or both, this can be an indication for you to consider a depressive symptoms. Also, if there are 5 check marks in the shaded section, including question number 1 or question number 2 or both, then you may want to consider major depressive disorder. On your handouts, we've also listed other mood disorders criteria, or the list of just mood disorders that you could use as your for your own reference. And on this slide, we also pasted the notes section for the PHQ-9, and pretty much what it says is for us to be more mindful when making the diagnosis for mood disorder and take into account our patient's understanding of the questionnaire, and also to take into account other factors such as normal bereavement, history of manic episode, other physical or medical conditions, and other drug use before we make our mood disorder diagnosis. So on this slide, we basically provide the total score range to determine our client's depression severity. So as you could see here, when clients have total score of 1 to 4, it is, in terms of the severity, they have minimal depression. 5 to 9 indicates mild depression. 10 to 14 indicates moderate depression. 15 to 19 indicates moderately severe depression. And 20 to 27 indicates severe depression. So in terms of when to use the PHQ-9, as I previously mentioned, PHQ-9 can be used during initial assessment or during intake session, and this can help us to identify initial problems and symptoms for our clients. And in addition to that, PHQ-9 can also be used as an ongoing assessment to measure or to determine session topics and to assess effectiveness of treatment. We really recommend that you ask your clients to complete the PHQ-9 in the beginning of a treatment session. And the reason is so the results of their PHQ-9 can inform our therapy session and could guide us to decide what type of topics that may be relevant or important to cover in the therapy session. So for instance, if because the PHQ-9 has item number 9 or suicidality, if we notice that our client's suicidality elevated for a specific session, then we can make sure to focus on this area first before we talk about other things. The downside of using the PHQ-9 at the end of the session is we may not catch this important information early enough, so we might not include the discussion about suicidality, for instance, in the therapy session. So now I just want to spend some time to talk a little bit more about the research evidence behind the PHQ-9. The self-report measure was initially developed by Cronky and colleagues, and in multiple research studies, the PHQ-9 has been shown to be a responsive, valid, and reliable measure of depression treatment outcomes. And what's really nice about the PHQ-9 is the fact that studies have shown that changes in the PHQ-9 score correlates or correspond with changes in depression diagnostic status over time. In the next section, we're going to talk a little bit more about the clinical utility of the PHQ-9. So at this point, if you feel a little bit tired or started to drift off, then I would really encourage you to stop and take a break, probably stretch just to be more energized before we start the next section. Okay, now is another point that I think will be good for us to take a break from the didactic and for you to grab a paper and a pen and think about, as well as write down, what is the clinical utility of systematic monitoring in your own practice. This can be related to your own use of PHQ-9 previously, or of other self-report measure or other assessment tool related to measurement-based care. Now, hopefully, you've thought about or jotted down some potential clinical utility of PHQ-9 in your clinical practice for you as a clinician as well as for your clients. Um, so in the next few slides, I want to highlight several clinical utility of depression-specific measure or of the PHQ-9. And what I want to highlight is the fact that some of the information in this section we actually gathered from clinicians at Centerstone when we did our pilot study. So I thought it's just really nice to share with you what your colleagues at Centerstone think about the utility of PHQ-9 in their own practice. So the first clinical utility of the PHQ-9 is that it can be used as a tool to assist our initial goal setting. So for instance, when you ask your client to complete the PHQ-9 and go through the different items on the PHQ-9, you could immediately identify the different areas that your clients are struggling with or areas where your client scored higher. So for instance, you probably could identify that your client was struggling with their sleep, for instance. This information can then be used integrated in their client's goal setting if that's something that your client is interested and found to be beneficial to work on. So when you're creating your treatment plan and your client's goals in treatment, you could then incorporate working on sleep, for instance, because you've implemented the PHQ-9 early in treatment. The second clinical utility of the PHQ-9 is that it can help with coordinating care and communicating in a multidisciplinary setting. As I mentioned before, the PHQ-9 has been used not only by therapists, mental health therapists, but also by other medical providers such as primary care doctors or psychiatrists. And because it is a standardized measure and we ask clients to complete the same questions regularly, we can communicate the client scores with other providers easily. So for instance, if you are coordinating care with your client psychiatrist who prescribes their antidepressants, for instance. If you are using the PHQ-9, the psychiatrist most likely is also familiar with the PHQ-9, and when you coordinate care, you could mention to the psychiatrist if your client is doing better or worse in terms of their PHQ-9 score. So again, the PHQ-9 can just be another tool to help you communicate with other providers easily. Clinicians at Centerstone also reported that the PHQ-9 can be a useful tool to assist them when they're trying to make diagnosis for their clients. It can also be used to make differential diagnosis, for instance. The fourth clinical utility is that the PHQ-9 can help them to track suicidality. So you don't have to verbally ask every time for someone who is always suicidal, for instance. And for other clients who probably don't frequently struggle with suicidality, when you implement PHQ-9 regularly, this can be a good alert system for you in case at some point their suicidality score elevates. So, clinicians at Centerstone have also reported that the PHQ-9 can help stuck clients to get unstuck. And I'll use an example for this point here. So imagine you have a client who's been completing the PHQ-9 regularly and who's been struggling with depression for a while. And the primary target in therapy session is to help them to do better at work or at school, for instance, because work has brought a lot of stress into their life. And what you've been doing in treatment is to help them with some behavioral and cognitive strategies so they could probably be more assertive to their supervisors or to communicate better with their colleagues. But what happened is you notice that their depression symptoms remains pretty high and they're not improving in therapy. So you could use the PHQ-9 and the previous data that you've collected based on the PHQ-9 to look at other areas that may have not been addressed in therapy. And in this example, you've probably noticed that their sleep was not well. They've been struggling with sleeping significantly since the start of treatment, and you could spend some time to discuss this with your client and ask if one of the primary barrier for them to perform well at work is because they don't have a good routine, that they're themselves still struggling with day-to-day routines such as sleeping and eating. And maybe because you identify this other additional area that you haven't addressed, you could either add a new strategy or switch the focus of therapy for some time to first address this basic daily functioning issue that's really important to take care of before you ask your clients to engage in other more complex cognitive and behavioral strategies. So that's just an example of how the PHQ-9 can help stuck clients get unstuck. Another potential clinical utility of the PHQ-9 is to provide you with some benchmarks on what is your client's norm in terms of their depressive level and how they are compared to the general population. And I've mentioned this point also before. This particular PHQ-9 clinical utility was in line with the other points that I've previously made. Some of the clinicians at Centerstone reported that the PHQ-9 can serve as another set of data points to help focus session materials. So, for instance, in the beginning of the therapy session, you ask your client to complete the PHQ-9. And you identified some of the items where the scores were elevated. You could then use this to set the agenda for that specific therapy session. And for instance, you could use this data also to remind clients or to redirect clients to the focus that you've decided together in the beginning of session to focus on. So for more concretely, for example, for clients who tend to deviate from the agenda of treatment, instead of talking about how they've been feeling hopeless about the future, they probably start to talk about other interpersonal issue that's important to be addressed, but you may need to address this hopelessness first in the session and then come back to the more interpersonal problem later on down the road. You could then use the data from the PHQ-9 to redirect client back to the focus of the session that you've decided together in the beginning of the session. As I've also previously mentioned, clinicians have reported that the PHQ-9 can alert them when clients experience worsening depressive symptoms that may not otherwise be caught if you're not implementing the PHQ-9. So for instance, for a client who's not as assertive, they're probably feeling a little bit worse, but did not really share with you how they've been feeling, but because you regularly implement the PHQ-9, you have a more concrete way to assess the changes in their depressive symptoms. So this is my personal favorite on the clinical utility of the PHQ-9. The PHQ-9 can help engender hope and provide a more objective evidence for your client's improvements, right? Wouldn't it be nice when you regularly provide the PHQ-9 to your client and then you have their chart or the trajectory of their PHQ-9 symptoms? Then you could show your clients on paper when they're improving in treatment. You could let them know that in the beginning of treatment, this was their initial PHQ-9 scores, and after working with you, after the clients put a lot of work into therapy, and you could see that they're feeling better and that they've made a significant progress in treatment also. So I thought that this clinical utility can be very beneficial for client because we have a more concrete data when they are doing better. We also know that for someone who's struggling with depression, even when they've been making a lot of progress in treatment and that they've been feeling better, depression symptoms can come back and they can feel worse even after they're working really hard. So for instance, for a client who suddenly has a significant external stressor in their life, and then you see based on their PHQ-9 scores that their depressive symptoms have been elevated. You could then use this data to validate their experience and highlight the relationship between what's going on in their life and the change in their PHQ-9 scores. I think this can be a tool to really validate the client's depressive symptoms changes. You could say that, you really understand why the PHQ-9 score elevates because of all these stressful events that are going on currently in your client's life. And here are just some quotes that we got from clinicians at Centerstone on their perception of the clinical utility of PHQ-9. So for the first one, this clinician highlighted the use of PHQ-9 to validate clients' experiences. He or she said, "I would love to be able to choose this if I wanted it as an enhanced, way of saying, oh yeah, I really understand the way you're feeling. Not only am I hearing this, but here's another way to look at it." And the second quote was related to the use of noticing the client's trajectory and the changes in their depressive symptoms. He or she said, "I like to have a client occasionally be able to look back and see either their progress or their patterns, because I do have clients that go like, and I think that's a really good information." Alright, now we are getting into the practical side of the PHQ-9. In other words, we're going to focus on the different skills and strategies that we found helpful when we're trying to implement measurement-based care with our clients in our actual practice. So I really think that this is the meat of this training, which is focusing on the skills on what to do when you first start implementing measurement-based care with your client. So I hope you've enjoyed the presentation so far and that you're willing to answer to the prompts that I've prepared for this section and to practice it yourself, delivering the PHQ-9 with a hypothetical client, or just to imagine what you would say when you're sitting with a client in the room trying to introduce the PHQ-9. Now before we move on, this is just a quick self-test to see if you remember the 3 core components of implementing measurement-based care that I mentioned earlier in this training. Alright, so I hope you still remember the 3 core components of measurement-based care. As I mentioned before, the first one is to actually administer the PHQ-9 to the client. This is where you ask your client to start completing the PHQ-9 regularly, and provide the PHQ-9 to your client in the beginning of each session. So one thing that I want to highlight here is we've received a lot of feedback from clinicians at Centerstone that one thing to help administering the PHQ-9 more efficiently is to work with office professionals, for instance, to help delivering the form while the client is waiting for you in the waiting room. This way, you collaborate with the office professional and ask them to provide the clipboard with the PHQ-9 form to your client while they're waiting for you. And this way, when they start therapy session, they already have a completed PHQ-9 for you to score and enter to the electronic health records. In addition to that, if the strategy is not feasible for your practice, for instance, some clinicians have also mentioned that sometimes they allow clients to complete the PHQ-9 in the beginning of each session, or to even go through the PHQ-9 items with them together. We have printed the scoring board in your training packet, so I just want to highlight that and refer you to this printed board that you could fold and put maybe next to your computer or on your desk facing your client, so when you go through the PHQ-9 item scores with your client, this scoring board can just be a tool to remind your clients the different scales or the different ranges that they can give for each item. The second core skill of measurement-based care, particularly in implementing the PHQ-9, is to enter the PHQ-9 scores of your clients to the electronic health records. And in this case, you may be using My Avatar or the CenterNet. And also to review their PHQ-9 scores yourself. So for you to go through the scores and make sure that you notice the total scores, for instance, and the specific scores for important items such as the suicidality. After you administer the PHQ-9 with your client and you enter their scores into the EHR and you review their total scores as well as individual scores, the third core skill is to discuss the PHQ-9 with your client, to actually share the results of the PHQ-9 form that your client just completed and go over the results together. When you administer the PHQ-9, there are several micro skills that we've prepared for you to consider in the administration of the PHQ-9. So the first step is just to identify clients where depression is a concern or focus on treatment. The second micro skill when you're administering the PHQ-9 is to provide the rationale of PHQ-9 administrations to your clients, or to provide the reasons why you think it's important to start measuring their depressive symptoms regularly. The third micro skill when you're trying to administer the PHQ-9 is to prepare the form prior to therapy session. And again, I just want to highlight that if possible, you may be able to work with office professionals to prepare the PHQ-9 in advance and give it to your clients while they're waiting for the therapy session. The fourth component of administering the PHQ-9 is to request your clients to complete the PHQ-9 in the beginning of each session. For the fifth skill of administering the PHQ-9 is to provide reminder of PHQ-9 brief instructions to your clients if needed. So my hope is in the beginning of implementing measurement-based care, when it's the first time for you to ask client to complete the PHQ-9, you may need some more time to explain the instructions to your clients, but my hope is after your client becomes familiar with the form and completes it for several sessions, that you don't have to consistently repeat the instructions for the PHQ-9. Lastly, if needed, you can also assist your clients in completing the PHQ-9. Maybe for some clients who are struggling with reading proficiency, for instance, or for clients who are struggling with some cognitive functioning, then you may need to assist them to complete the PHQ-9 items. Now I just want to go through some elements or points that may be important for you to share with your clients when you first provide the rationale on starting measurement-based care or starting implementing the PHQ-9. First of all, you could share with your client that measurement-based care is used to inform treatment, and that research has suggested that clients can get better faster when we consistently monitor their symptoms. You can also explain that when you start measurement-based care, there are several activities that are expected to do for you and your client. The main one for your client is to complete the form, the measure, or in this case the PHQ-9 in the beginning of the session. And then you will also score and interpret their responses, and that it's really important for you and your client to discuss their scores in session. When providing the rationale, you could explain to your clients that the main goal is to improve therapy and gain a better understanding of your client's most important problems. Another benefit of implementing the PHQ-9 regularly that you can share with your client is the need to consistently assess their presenting problems over time to see if progress is being made. And if progress is not being made, having this concrete evidence can help to alert you and your clients to think about other necessary change or other strategies that you haven't tried in session that may be beneficial for your client to start trying. On the next slide, I want to share with you an audio recorded role-play therapy session that we've prepared to model how to provide the rationale for using the PHQ-9 with your depressed client. So hopefully you enjoyed the role-play recording, and I would encourage you to write down any feedback or questions after you listen to the modeling, and to also maybe practice providing the rationale yourself by imagining on the type of things that you would say and explain to your clients when you first ask them to complete this new form. Hi Meredith, how are you doing today?
I'm okay.
So it's good to see you this week. And you've probably noticed that I asked the office professional to give you this new form while you're waiting for me today.
Yep.
So I thought we just need to spend a few minutes so I can provide the rationale why I gave you this new form. So a few weeks ago, I completed this training on measurement-based care, which is a new practice that has been recommended. And the idea of measurement-based care is to ask clients to routinely monitor their depressive symptoms by completing this form called the PHQ-9. And there are some benefits of routinely monitoring your depressive symptoms. So, can you think about some benefits of why we should regularly monitor your depressive symptoms?
Well, I guess you would know maybe if I was doing okay or like sleeping okay.
Yeah, definitely, because we ask the same questions every week or every time I see you for therapy. So, this way we could see the changes that you've made regarding some of the symptoms, right? So, if we regularly monitor your symptoms since the start of the therapy, in the middle of the therapy, and at the end, we could see if you've made any progress or if you've improved. So that's definitely one of the benefits. The other benefits of using this measurement-based care is, let's say somehow you are dealing with some stress in your life and your depression level increases or you're doing worse. Because we monitor your symptoms regularly, we can catch that earlier, right? So then we could discuss your progress in session, and then it can inform me to think about adding maybe new strategies or changing what we're doing in therapy or changing our focus in therapy too. So it can also be another tool to alert us when things are not going well. Okay. So do you have any questions? The plan is for me to ask you to complete the same form in the beginning of each session. You'll bring it to therapy session and I'll score your completed form, and then we'll discuss the results together.
So is this all we're going to be doing in therapy now?
Hopefully not. It can be. So, for instance, if you've completed the PHQ-9 and there are areas that you think we should focus on, so if you're struggling, excuse me, if you're struggling with sleep, for instance, then we can focus session on improving your sleep. But if you feel like there are other areas that we should discuss in addition to the PHQ-9, then we can also maintain that balance.
Okay, that makes sense.
Okay. Are there other questions that you have regarding the form?
How long does it take to do? Do I have to come early?
Well, how long did it take you today to complete it?
I guess I didn't really notice, but it didn't seem that long.
Yeah, typically it takes probably about 3 to 5 minutes to complete. Today, I assume it would probably take you longer since this is the first time you completed it and you had to read the instructions. But my guess is it's going to take about less than 5 minutes. You can come early, like 5 minutes early if you want, but if you don't have the chance, then you don't have to. We can you can just complete it while you're waiting, or in the beginning of our session we can go through it together too.
Okay.
All right, well, if you don't have any more questions, I think that's all I have to say about the PHQ-9.
Okay.
This was the scorecard that I mentioned earlier that we've printed for you and included in your training packets that may be helpful for you to share with your clients when you're administering the PHQ-9. Here are just some core skills that we've identified when you try to enter and review the PHQ-9 in the electronic health records. So the first one is to access your client file in CenterNet or maybe My Avatar if your clinic has switched from CenterNet to My Avatar. The second skill is to enter your client item responses in the PHQ-9 tab. Once you enter the PHQ-9 scores, you can then review your client's total score. we also encourage you to review your client's specific item scores. So pay close attention, for instance, to item number 1 or their suicidality score. The fifth micro skill is to review the trajectory of scores over time. I will talk a little bit more about the graph and the trajectory of your client's PHQ-9 scores later in this presentation. And the last micro skill that we encourage you to do is to look for a 5-point change. Research has shown that 5-point change in the PHQ-9 scores is a clinically significant change, particularly within the first 5 treatment sessions. Now, I just want to stop and point out that we have also prepared 2 instructions for you on how to enter the PHQ-9 scores to either CenterNet or My Avatar. So you may still be using CenterNet and will switch to My Avatar in a few months, or you probably switch into My Avatar also. So we thought to prepare both instructions for you. So on this slide, I'm going to talk a little bit more about entering the PHQ-9 scores into the EHR. The screenshot that we have included on this slide may not look the same as the one that you have on your EHR. So I just want to point that out. And the main things that I want to highlight is when you're entering your client's PHQ-9 scores, is to transfer each PHQ-9 items from the paper format that your clients completed into the EHR screen that is already included in your EHR system. So after you enter a specific score for each PHQ-9 item, then the total score will automatically be generated, and you could review the total score and discuss it with your client. Now, once you enter the PHQ-9 scores to the EHR regularly, your EHR is equipped to produce this trajectory graph. And I just want to acknowledge that the screenshot that we've provided or we've included on this slide may not look the same as the one that you have on your EHR, but the basic idea is the same, that when you regularly enter the PHQ-9 scores of your client, you can go to their profile and access this symptom trajectory. I think this graph is just a nice tool to be shared with your clients when you discuss their PHQ-9 scores, just to concretely show them how they've been progressing in treatment and the type of changes that they've been reporting in terms of their depressive symptoms. The other thing that's really important that I want to point out is to maybe print this symptom trajectory during your therapy session and share it with your client, maybe for them to take home. On the instructions that we've printed for you in your training packets, we've also included some instructions on how to print the trajectory graph from your EHR. So now that we've talked more about how to administer the PHQ-9 with your clients, how to enter the scores to the EHR and print the trajectory graph and discuss the graph with your client, I want to spend a few minutes talking about the fidelity questionnaire that I mentioned earlier in this presentation. So I was wondering if you could just stop and go back to your training folder or training packets and pull out the fidelity questionnaire that I mentioned. And just to give a brief background, initially we plan to not only support your use of PHQ-9 but also to assess your fidelity in implementing the PHQ-9 with your clients. And we have included 3 very brief questions to assess clinicians' fidelity. First, we'd like to assess whether or not you administer the PHQ-9 or whether or not your client completes the PHQ-9. We are also interested to assess whether or not you review the PHQ-9 or you review your client scores. And lastly, we're interested to ask whether or not you discuss the PHQ-9 scores with your client. Um, and our initial plan was to include these 3 very brief questionnaires in your progress notes in the EHR. So it would be very easy for you to complete after you write your progress notes, to just answer these 3 very basic questions. Um, the idea is definitely not to require you to use the PHQ-9, but even if you decided not to use the PHQ-9, I think it will just be a very interesting data for us to learn what are some potential barriers or reasons why you decided not to use the PHQ-9 with your client. So as you could see on this slide, this was our initial plan, to include these 3 questions on the EHR. Unfortunately, this plan didn't go as well as we hope, and we and the IT team, we couldn't manage to include these 3 questions in time into your EHR. So we had to think about some other alternatives, and we came up with this option, which I agree that it's not the best option, but the one strategy that we could think about is to give you this fidelity questionnaire that we've included in your training packet. With this questionnaire, what we ask you to do is to briefly complete this questionnaire at the end of each day, hopefully, and just to identify the depressed clients that you see that day, and to answer these 3 very simple questions. Having said that, I acknowledge that this is probably putting a lot more burden on you just to complete this additional questionnaire every day. So even if you decided that, this is too much for me, I can't add another component to my everyday practice, you can still participate in this study. And we also have thought about some incentive. This is a very minimum incentive for asking you to complete this questionnaire. We've included a dollar bill for each week of the fidelity questionnaire that we ask you to do. So what do you do with this questionnaire? What's going to happen is we'll send you this questionnaire regularly. Our research team will send you this questionnaire, mail it to you. We'll ask you to complete it weekly, and at the end of the week to just drop this questionnaire to the mailbox that we've prepared for you as part of this research study, and our CRI research personnel will get this completed survey from the mailbox and send them back to our research team. So if you have any questions or concerns regarding this additional fidelity questionnaire, feel free to shoot us an email, and we'd be very happy to talk further with you regarding this additional piece. So for this next section, what I want to do is to share with you 2 videos of a hypothetical therapy sessions where the therapist provide some modeling on how to discuss the PHQ-9 with her client, her hypothetical client. And what we thought would be interesting is to include some modeling where the clients are pretty resistant to PHQ-9. We've heard a lot from the clinicians that one of the primary concerns for them is if their clients are resisting to complete this new or added measure into their therapy session. So we thought it would be interesting to share with you some example of an resistant client who doesn't really want to complete the PHQ-9 or discuss it in therapy session. The second video that we've prepared for you portrays a hypothetical depressed client who comes to therapy session feeling very upset because there's a lot going on in her life, and how the therapist managed to validate her feelings and emotions and how upset she was, and at the same time still review the PHQ-9 and discuss her scores. So I would let you spend a few minutes to just watch these two videos. I would encourage you to write down any feedback that you have, any questions that you have that we may be able to discuss further if you decided to participate in our consultation meeting. Now in the next sections, I'll spend a few minutes discussing potential steps and strategies that you could use when you're working with clients who struggle with lack of progress. So there are 4 main steps or recommended strategies to address lack of progress with your clients. And the first one is just to identify lack of progress early. And this way can be done when you implement the PHQ-9, for instance, routinely since the start of treatment. So as I mentioned before, when you consistently deliver the PHQ-9 to your clients, you could monitor their symptoms or their PHQ-9 total scores and individual scores, and you could compare and contrast how they're doing in the first few sessions, in the first 5 sessions, for instance. And this way, if they're not making significant progress, if their PHQ-9 scores remain the same, remain elevated, or even got worse, you could identify this issue very early in treatment. This is just an example of a hypothetical client who is not making enough progress early in treatment. So as you could see here, this graph represents her PHQ-9 score data. And for session 1, you could see that her score was a little bit above 20 on the PHQ-9. Even though it decreased slightly on the second session, it wasn't a significant decrease on the PHQ-9 scores. And you could see that in the first 7 sessions, her PHQ-9 scores remain on the 20s level, indicating that she's not making as much progress early in treatment. The second step, once you identify lack of progress early in treatment, you can start thinking about some potential reasons on why she or he is not making as much progress in treatment. So the second step is just to generate hypotheses about the causes of the lack of progress. Now, when we think about some reasons for the lack of progress, definitely there are a number of potential reasons. So reasons can come from external circumstances. It's possible that our clients are struggling with current stressors or negative life events that really impact their depression score, for instance. It may be all due to not addressing the actual concerns or the core problems that perpetuates their depressive symptoms in treatment. So those are some 2 potential causes of lack of progress. Now I was wondering if you could stop for a few minutes and jot down some potential reasons when your clients are not making as much progress in treatment. So I hope you've jotted down some potential reasons that may lead to clients' lack of progress. And hopefully some of the responses that you've already thought about or written down are in line with this potential hypotheses or reasons that we've prepared in this training. So one of the potential causes of lack of progress is clients' low readiness to change. Clients may start therapy because they're struggling with certain issues, and yet the timing is not right for them to make concrete changes immediately. They may not be ready to start implementing the recommended treatment plan, for instance. So that can lead to lack of progress. Another reason is unclear treatment goals. We may not have had the opportunity yet to really sit down and collaborate with our clients to identify concrete goals that they want to target in therapy. In line with that, we might not have sufficient treatment plan yet. Uh, Again, we may not have the opportunity yet to really sit down and think about case conceptualization and concrete treatment plan that will hopefully be beneficial for our client. The fourth reason is that treatment plan may not be fully implemented. So an example of that is when client is not doing homeworks that we collaboratively decided to do outside therapy session. Another reason of lack of progress is substance misuse, in addition to the primary diagnosis that we're targeting. So substance misuse can definitely become a barrier for clients to engage fully in treatment plan. Maybe we don't have clear diagnosis for our clients, or maybe we need diagnostic clarification before we can move on to create a concrete and targeted treatment plan. Another potential reason is the absent or unclear case formulation. It's possible that we don't fully have all the important information to create a solid case formulation, so additional interviews or additional information gathering may be needed so we can tweak and make our case formulation clearer. Lastly, it's very possible that lack of progress is led by low social support outside therapy sessions. So our clients may not have people around them who could provide adequate support for them when they're dealing with certain diagnoses or when they're dealing with negative life events. So what are some strategies that you can use when your client is struggling with low readiness to change? One tip that we have is to include another assessment to further assess your client's readiness to change and where they're at in terms of the stages of change. There is a measure that you could implement in addition to the PHQ-9 to further assess your client's readiness to change early in treatment. Motivational interviewing strategies can be used to address this issue, specifically to develop discrepancies, to roll with your client's resistance to change, and to engender change talk through reflective listening. When we struggle with unclear treatment goals, we can go back to the drawing board and ask ourselves, are the goals realistic? So we can discuss this too with our clients. How realistic are the goals that we've discussed previously? Are the goals concrete, observable, and behavioral goals? So sometimes we or our clients may identify goals that are less concrete. So they may say that they just want to be less depressed. So it's important to consider other goals that are more measurable. So what does that look like when they are less depressed? What kind of things that they are doing when they're feeling less depressed? And that way we can have a more measurable goal to schedule and help our clients to engage with. Are these goals based on our clients' own words? Are they something that are really important for our clients and in line with their values? Or are these goals that are mostly recommended by us as the clinicians without really considering what's important for our clients and their lives? Are there smaller goals that could be listed that may lead to their bigger goals? So another example is for a client who wants to find a job, and at the same time they may be struggling with specific skills that they could sell to apply for certain positions. So in that case, instead of immediately focusing on revising their resumes or applying for jobs, we may want to step back and first focus on enhancing their skills by engaging in additional trainings and things like that. To address insufficient treatment plans, we may want to ask ourselves if sessions are held frequently enough. Is the treatment intensity adequate for our clients, or if we need to start considering other additional or adjunct treatments such as medications if needed. So when treatment plan is not fully implemented, here are just some strategies that you could consider. First, you may want to consider if there are therapy interfering behaviors that consistently occur in session. So for instance, even if we have a concrete goal of helping our clients to find a new job, for instance, but they struggle with maintaining their focus on concrete behavior goals to engage in activities that will help them to find a job, or if they struggle to complete the homework or attending therapy sessions regularly or in time. Another potential therapy interfering behavior is if there are crises that consistently occur that our client struggle with, and that way every therapy session is spent to focus on the crisis that they're struggling with. Another strategy is to further assess whether or not our client fully comply with all aspects of treatment, such as homework completion in between therapy session, and other goals that we've discussed and agreed upon for treatment. Do all members of treatment team agree on the formulation and treatment plan? So it's just a good point for us to stop and discuss with our clients how do they feel about the treatment plan. If there's, as I previously mentioned, substance misuse can lead to lack of progress. So we definitely want to consistently assess whether or not substance use interfere with the patient's ability to implement or benefit from therapy. And to do that, you could again add an additional measure to assess their substance use. For instance, there are some self-report measures out there that have been shown to be valid and reliable to assess substance misuse. And if there is any substance misuse, it's probably a good time for you and the client to consider if you need to focus on their substance misuse first before targeting other areas that they're struggling with. So another potential reason for lack of progress is when diagnostic clarification needed. In this case, you can probably start considering if there are other diagnoses that better explain your client's symptoms. It's possible that depression is not the primary diagnosis. So you may notice that even though their PHQ-9 level is elevated, it may not be the primary symptoms that your client's struggling with. There may be other comorbid diagnosis that will be better to be targeted first before you target their depressive symptoms. So for this point, I want to share with you an example of studies where when they address just the depressive symptoms and the client is struggling with other comorbid conditions, both their depressive symptoms and other diagnoses didn't get better. However, when they address the other diagnosis, so for instance, clients who struggle with panic and depression symptoms, when the therapist addressed the panic symptoms first, they found that both panic symptoms and depressive symptoms got better. Same thing with adolescents population. For adolescents who struggle with depression and PTSD, one study found that when they just target the depressive symptoms, both depression and PTSD didn't get better. But when they address the trauma symptoms first, both diagnoses got better. So that's just another example of why considering other comorbid diagnosis and whether or not it's important to target one diagnosis first over the other. So in terms of absent or unclear case formulation, it's important for us as clinicians to ask ourselves whether or not treatment guided by formulation. Do we have enough information to understand and identify the predisposing, precipitating, perpetuating, and protective factors that maintain our client's symptoms or that can help improve our client's symptoms? And if we have identified these factors, it's important to ask ourselves, are we actually targeting the perpetuating factors with the treatment plan and therapeutic strategies or interventions? So if we feel that social support may contribute to our client's lack of progress, it's really important for us to sit down with our client and further assess whether or not low social support interfere with treatment implementation. So for instance, clients who struggle with depression and have very low motivations to engage in daily functioning such as eating, exercising, taking a shower, it may be really important for them to receive additional social support from their family members or friends. And low social support from their social networks may really influence their ability to engage in this healthy daily routine. So it's really important for us to further assess the quality and extent of our client's social support. Another potential strategy is to consider whether or not we regularly look for ways to help our depressed client increase feelings of closeness with others. We have learned from research that social support is a really important factor to help with to help our clients who struggle with depressive symptoms. So this point is really important for us to consistently assess and consider in treatment. Now, after we identify our client's lack of progress, hopefully early in treatment, and after we generate some hypotheses or predictions about the causes of lack of progress, the third step is to actually discuss the lack of progress with the client. And I know this can be pretty challenging, and on the next slides, we have some tips and tricks that you could consider when you're trying to discuss the lack of progress with your client. When you're discussing lack of progress with client, I think the first step that we all should remember is that it is a difficult conversation, not only for your client, but also for you as a therapist. So I just want to acknowledge that from the start because you may feel uncomfortable or wanting to avoid this discussion, and while that's really understandable, it may not be the most helpful thing for our client. The first tip that we suggest is for us to adopt a curious stance. Because hopefully we have the data from the PHQ-9, we have the trajectory after we chart their depressive symptoms regularly in the past several sessions. We could bring the graph into the session and present it to our client, and using a curious stance, ask them to let's just look at the data together. The next step is to gain feedback from our clients and ask them if the data match with their experiences, whether or not it correlates with how they're feeling and how they perceive their depressive symptoms have been in the past few weeks, for instance. We could use case conceptualization that we've prepared in treatment to anticipate our client's response. Clinicians should be prepared to discuss the client's discomfort when discussing the data. So you could say things like, I understand that it may not feel easy to have a discussion when we're not making progress in treatment, or when we notice that your depressive symptoms remain elevated or got worse. So just to validate and put out there, highlight the discomfort and how understandable it is for our client to experience uncomfortable emotions when we discuss lack of progress. Using open-ended questions is always important. So some of the examples is to ask your client, how does that fit with what you're experiencing? Or what do the results suggest to you? Instead of just providing immediate explanations on what you perceive their scores mean, to just generate data and generate more engaging discussions with your clients to understand their own perspectives also. So when your client is not making as much progress, another tip that you could do is to discuss what the score trajectory usually indicates. So for instance, when their scores remain elevated, you could mention it to your client that it may be an indication that we haven't targeted the core issues or the core factors that maintain their depressive symptoms. Building a collaborative environment by working together with your clients to generate hypotheses about what's getting in the way or what might lead to better progress is another tip that we would highly recommend. When your clients are struggling with ambivalence, we recommend that you use reflective listening that incorporates assessment results based on the PHQ-9. So for instance, you could say, you're not sure if it's worthwhile to be here, but your assessment results suggest that you're feeling more depressed than other adults. So once you have the hypotheses that you generate in collaboration with your clients, the last step to address lack of progress is start to collect some data and test the hypotheses based on this discussion of your client's lack of progress. You've probably added new therapeutic strategies that you haven't tried previously, and your clients may agree to try different things and new things. And once you start implementing those changes, you could consistently go back to the PHQ-9 scores to see if there are progress made after these changes and if your hypotheses were supported. So now I've spent a lot of time discussing different tips and tricks that we came up with to help you address lack of progress. So my guess is that you probably have some questions and points that you would like to further discuss. And hopefully we'll have the opportunity to further discuss this issue if you decided to participate in the ongoing consultation that we offer after this training. We're almost at the end of our training today, and for the next section I want to spend a few minutes to discuss the next steps of participating in this research study if you're still willing to continue your participation. So as the next step of your participation in this study, we hope that you are interested to join the consultation meetings that we offer after you completed this online training. The primary goal of this consultation sessions is to support your use of measurement-based care with fidelity. We invite all clinicians who participate in this research study to join these consultation meetings and potentially to include some office professionals and other staff to help support the implementation of measurement-based care in your clinic. As I previously mentioned, these meetings will occur via web-based platform. I will facilitate the meeting, or Dr. Lewis will facilitate the meetings with you, and we will meet every 3 weeks or tri-weekly for about 60 minutes each meeting. For this consultation meetings, we encourage all of you to bring some questions about using the PHQ-9 with your actual clients, and to generally talk about measurement-based care framework approach. We will also consistently discussing how implementation of PHQ-9 is going in your own clinic. So the primary goal of this project is to support you to use measurement-based care with all clients carrying depression diagnosis or for which treatment has depression focus. The initial idea to help you easily identify who to implement the PHQ-9 with, we've discussed with Centerstone and the IT team to create the pathway codes for clients who have major depression as their diagnosis, and to include these clients into the depression pathway. So when you open their profiles, you can get alerted who are these clients who are enrolled in the depression pathways. However, unfortunately, the system is not yet fully finalized. So at this point, you may not receive an alert showing who to implement the PHQ-9 with. But hopefully this will be the goal that we continually working on with Centerstone to include, to make it easier for you to identify who to deliver the PHQ-9 with. So one thing that I haven't really mentioned in this presentation is the plan to also recruit clients in this research study. I have discussed in detail our plan to recruit clinicians and potentially office professionals and administrators at Centerstone to participate in the study, so we can understand the process of implementing measurement-based care at Centerstone. And at the same time, we're also interested to study how implementing measurement-based care influence clients' outcome. So what does that mean to you? It means that your clients that you see currently might be contacted by our CRI research specialists to participate in our study. Again, I just want to mention that your job is not to consent client or to recruit clients. Our CRI research specialists will do this work on the back end and contacted your clients directly if they meet the criteria to participate in this study. However, that may mean that your clients come to therapy sessions with some questions regarding their participation in this research study. Again, we don't expect you to do much when your clients come with some questions, meaning we don't expect you to really know all the details about our research studies, but we have provided you with some frequently asked questions that you could share with your clients in case they come into session with some questions. We've also printed some brochures for client recruitment that if you're interested to share with your clients who may be eligible to participate in the study. Again, I just want to highlight that the goal of this research study is to determine optimal approach to implementing measurement-based care. So even if you choose not to use MBC with Fidelity or at all with your client, we hope that you will still continue your participation in this study because even if you're not doing MBC, it's still very important for us to investigate why MBC is not being used. On this slide, I just want to provide some brief summary to just clarify on the research activities that you may be asked to do. And on the left column, those specific activities are intended for office professionals, and on the right column are the list of activities that I've talked about before that we will ask you to consider participating in. So the first one is to potentially provide the client brochure if they have any questions, to review client PHQ-9 and enter the scores into the EHR and discuss the scores with your clients, to fill out the surveys at baseline, 5 months, and 15 months follow-up, to potentially participate in implementation team meeting or our consultation meetings that will start 3 weeks after this training. Potentially to submit audio recorded also of the therapy sessions so that you will be able to discuss more if you decide to participate in the consultation team meeting. Alright, we've reached the end of our training on implementing measurement-based care. I hope you enjoyed the presentation and found the materials beneficial for you and your clinical practice. And as a reminder, we need you to complete the CEU survey so we could provide you with your CEU credits after completing this online training. We have also included a brief survey to assess the effectiveness of this training, so I would really appreciate if you could take some time to complete those survey. We will mail the $15 incentive for you for completing the survey that we've included in your training packets. Again, if you have any questions or concerns regarding this training or your participation in this research study, I would encourage you to contact our project coordinator, Candy Arnold, and her card and contact information is included in the training folder or the training packets that we've left for you. So I look forward to be in touch with you, hopefully during the consultation meetings or when we visit your clinics a few months from now. And it's been a pleasure. Thank you. Bye-bye.